Good afternoon, everybody. Welcome to the first of our 4 webinars that we're hoping to provide over the next few months. This one, Making Rehabilitation Work Better for People, has some very interesting speakers that I'm going to introduce, but I would introduce myself first of all. My name's Jane Nicklin. I'm one of the associates of NHS Clinical Soft Intelligence Service, and I will be chairing today. We've got some great speakers. We've got Penny Roberts, who is a member of the NHS England Improving Rehabilitation Service Delivery Board. We have John Barrick, the Chief Exec of the Stroke Association, and we have Lindsey Hughes, who's the Rehabilitation Programme Lead for NHS England. And they will be providing different perspectives of this issue of people returning to the kind of occupation that they want to have. The webinar is 45 minutes long. We will have a session for questions at the end. We've been inundated with questions before we started, and we expect that there'll be some more that will come in today as we go through, and we will endeavour to answer some of them, but not all of them, I suspect, and we will then post everything else on the forum for people. This is being recorded and it will go online with the slides about a week's time, and we will make sure that there will be a link on our website for you to know where to find it. It will be on the RCSLT website. You can use 2 buttons while you're listening to this webinar. One is the Q&A button, which will allow you to submit a question, and we'll use those at the end, hopefully. There's also a chat button. So if you want to send an instant message to the team here, you can do that at any time during the event if you have a query. I think the learning aims are fairly clear, that we want to help you understand what's happening out there in terms of the system and how you can communicate with other people within the community of practice, and that we have people talking about a person-centred approach to returning to occupation. And we need you to understand how best you can engage with both the national and regional work. So, without further ado, I'm going to pass you over to my friend over here, Penny, who's going to be talking about what it's like to be a service user and the work that's going on from now on with this team. Thank you, Penny.
Hello. My name is Penny Roberts. 20 years ago, I had an accident which involved a spinal injury, and I very quickly in one day went from being a fit and active medical professional to a disabled person. I'm paralysed from the chest down. When I went into rehabilitation, I was taught that I would be a perpetual patient, really, that every area of my life would involve medical treatment and the experts would be in charge of that. So I wasn't to worry because everything was taken care of. And that rehabilitation actually terrified me more than having the accident itself, because I wasn't a different person. I just had an accident. And just being told that I wouldn't be able to return to what I was before was actually quite terrifying. People look at me and assume that I have no other function than to be cared for. My hands are paralysed. I'm paralysed from the chest down, and people just assume that I have no function. And I think education and a change of attitude in not only professionals but in the general population is the key, because I'm perfectly functional. I need to do things in a different way, and rehabilitation should empower people to get back to living life. We need to change our expectations rather than imposing a standardised care system that people can't escape. The care system that was imposed upon me wasn't going to suit me at all. It's now 20 years on since my initial rehabilitation, and I've had a child, I've got older, I've returned to work, and rehabilitation needs to be seen as something that supports you all the way through life, and not just something that happens in between being ill and being totally cured. I've had physiotherapy for 11 years, and if you looked at me today, I'm still in a wheelchair. So you'd think, oh, well, it hasn't cured her, so why are we still giving her physiotherapy? The reason I have physiotherapy is because it's integrated into my life. The picture you actually see here is me doing physiotherapy on a Saturday morning with my physiotherapist supporting me to drag my 8-year-old son along on roller skates. But it fits in with family life, it keeps me fit. And as a result of having support to suit my life, I now take no drugs, I have none of the expected health problems that I was told I would have 20 years ago, and I live a normal, active life. My initial input, as you could say, was more expensive than the standardised care of nipping to the hospital for physio and having district nurses come in and out and having a care worker that came in and got me up, get me dressed and everything. But it's now paid off because I've had no hospital admissions for 16 years. I've had a family. I've returned to work. I've just done all the things that I would have done in my life anyway. And that's the best value for me, even though the initial outcome may have been more than the cost of standard care services. I'd like to just now hand over to John Barrick, who's the Chief of the Stroke Association.
Thank you very much for that. I want to talk about some of the issues from the point of view of an organisation that's working with the NHS, with social care and many other groups in the community. We did a survey of stroke survivors' views on rehabilitation, around about 3,000 people, and they said that their biggest complaint was that they found it difficult to get access to the appropriate amount of rehabilitation. And in part, some of that is because the evidence that's often used in terms of what sort of services needs to be provided is very much driven by the concept of evidence or medical evidence, and it's quite difficult sometimes to have the appropriate sort of research that gives the appropriate amount of guidance. In this circumstance, we often wonder, why is it that the views of stroke survivors and their families are not given at least some important sense of weight within this whole process? Many of the stroke survivors told us that they felt that the overall system actually constrains patient-centric care, and that in many ways we need to step back and have a good look at the way that the system works. And what they want to see is a situation where they can be working with a group of rehabilitation workers, but also with others who can make a contribution to planning their care and making sure that the sorts of outcomes that they want, which are largely to do with quality of life, rather than issues just to do with making an improvement in the way that this muscle or that muscle worked, can actually be put into place. This is very difficult, of course, because for good reasons, the NHS is dominated by risk aversion. But if we are going to get integrated care, we do have to see the patient voice or the client voice actually coming in and having a much stronger role in actually determining some of the ways that systems are put together. We've found that it's very important to get a thought of what it is that the person actually wants themselves. What is the journey that they want to go on? Where do they want to get to? And within the context of understanding that broader approach, actually then beginning to design systems that will help people to get to where they want to be. I want to give you maybe a bit more detail now of some of the ways that we as a charity have actually been working in some of this. If I maybe move straight to a project that maybe is relevant to return to work. Across the country, we have a number of projects that are working on this, and they're put together in slightly different ways. About a third of strokes occur in people under 65, and as the world has changed and we are actually seeing more obesity and so on, we're actually finding that there are increasing numbers of people of working age who are actually having strokes. Now, in some areas of the country, this has been recognised, and there has been some funding advanced to do things in this area. One example is a project that we have in the northeast of England, where the expertise of the Stroke Association is actually used with a partnership with another charity that specialises in vocational rehab and helping people to get back to work. Now, the partnership, of course, also needs the assistance of social care workers and a multidisciplinary team, people who can continue to offer more intensive therapies, but everybody working together has been found to be the best way to actually get results. Now, one of the issues around this is how you would actually define success. And if success is always defined in terms of, yes, we will get the person back to work or into gainful employment, then I need to say, we don't actually get every stroke survivor back. But what many stroke survivors do is regain a control over their own life. They regain an ability to do something meaningful, such as regular volunteering. This actually means that the stresses and strains of family life, which can lead 46%, let me give you that statistic, 46% of stroke survivors will find that their relationships with a loved one break up after their stroke. So it's not just about rehabilitation to get back to work, it's about rehabilitation to actually get back to the key roles in life that are actually really important to people. And, the key roles may go beyond work, although for many people, of course, work and finance are intimately linked. We use lots of volunteers in these services. We have people who mentor people. We have peer support. There are many resources that get brought in. And in that sense, I want to say it's very important that when we're thinking about health and we're thinking about getting people back to a quality of life, we don't assume that the NHS is the only resource that can be utilised in this process. And there does need to be a real partnership approach to things. We have another project that's working in London, and this is actually finding out that because it works much more in a detailed way with individuals, but it's finding out one of the critical barriers here is actually not necessarily the rehabilitation system, but it's the rehabilitation of those in the workplace that actually needs to take place. Helping people who are employing, helping people who are organising work within the workplace to understand more about disability, about the needs of stroke survivors. And in fact, what's been discovered is that quite a few stroke survivors only begin to realise some of the issues around cognitive problems and so on once they're put in situations where they are being asked to contribute back to society. And it's only in those circumstances that a multidisciplinary team can then begin to address the sorts of issues that are around for that individual and their family. If you don't engage with life, then you're not going to understand the barriers and the blockages that are actually there from keeping you healthy, keeping you in a situation where you're not going to need to go back into hospital later on, and where you're not going to need to draw on expensive support for the rest of your life. Finally, I want to say something about self-management. We've been involved over the last 2 years in the creation of a self-management system that's been co-produced with stroke survivors and their families. And what this does is it's really taken the issues from the point of view of a stroke survivor and said, honestly, how much support do you get from medics or social care, and how much time do you spend having to try and manage all your problems on your own? The result, of course, is that the average we found was maybe 3-4 interventions a year from medics and so on. So people were left largely to their own devices or the support of their loved ones for large chunks of the year. So what a self-management program like we've put together enables is we have 49 different modules that are there, which covering all aspects of a stroke survivor's recovery and life. And the videos are co-produced with stroke survivors who are talking about how they have overcome various issues within their life. And they're also informed, of course, by therapists, making sure that the material is accurate. But the richness of data that comes from stroke survivors sharing with others, there's far more that this does. It's accessed via anything that can get to the internet. It has self-management programs on it, so as you achieve success, it'll send an email to your daughter and tell your daughter, I've done this today, so the daughter will actually phone in and reinforce to the person, what a fantastic thing, keep it going, mum, whatever it is. So even where families are fragmented, we're bringing in that mutual support of families and of others. If you're watching a video on incontinence, it'll tell you that there are other people watching. Would you like to talk to them? Would you like to discuss with them the sorts of issues? You can form friendship groups. It has calendars there. You can put your appointments in if you've got cognitive issues. I could go on and on for hours about this. This is a fantastic resource, but it's produced by stroke survivors with the medical and social care world to be able people to have ready access to self-management throughout the year. This is the sort of thing that the voluntary sector can bring into play. Let's work in partnership. Let's help to remake the system. Let's actually make sure that people can move towards quality of life and make a real difference to what we do in this country for everybody who's had a stroke and many other issues. Can I now introduce the next speaker, who is going to be speaking about rehabilitation and how it's going to be organised from the top.
Thank you very much, John. So the purpose of my presentation today is to outline the work being undertaken at NHS England to deliver the improvements for rehabilitation services, to tell you how you can engage with our work and discuss the vital role of sharing good practice and innovation in being able to deliver improvements in rehabilitation services. So first, I'd just like to give you a little bit of background to the programme. Our programme began in 2012 when Sir Bruce Keogh asked the Chief Allied Health Professions Officer to establish if there was a case of need to improve adult rehabilitation services. There was extensive stakeholder engagement to support this project, and the subsequent report told us that although there were good examples of service design and innovation, there was variation in the adoption and dissemination of this. Service users and clinicians told us that they were unaware of what services were available and how to access them. And we were also told that some services didn't focus on the needs of the patients and service users or the outcomes that they wanted. Following that initial piece of work, the Improving Adult Rehabilitation Services Community of Practice was commissioned by NHS England to address the need for a forum where good practice could be shared and disseminated. And I know there are a lot of people in the audience today that contributed to that initial piece of work that launched the programme. And I'd like to say thank you for your contributions and your continued support, because it has been the piece of work that has underpinned all work taken forward. One of the recommendations from that report was that a National Clinical Director for Rehabilitation be appointed, and in 2013 John Etherington took up post as the National Clinical Director for Rehabilitation and Recovering in the Community at NHS England, and together with the Chief Allied Health Professions Officer and her deputy is leading this work programme. At the beginning of this year, the Rehabilitation Engagement Project took place to develop principles and expectations of good adult rehabilitation services, for which we again undertook extensive stakeholder engagement. And this was to establish what principles should underpin good services, but also what our service users expect from those services. And we hope to publish these soon to give a national leadership to support local dialogue for solutions for effective rehabilitation service delivery. At the same time as that project was taking place, we worked with NHS IQ to publish good practice case examples to promote discussion and dissemination on good practice. And there will be a link to this document available on the website when the webinar is published. Within the last couple of months, the team at NHS England has grown from a team of 3, which was myself, John and Sheila Morris, to a team of 10. We now have a lead for rehabilitation in each of the 4 regions of NHS England, and their remit is to continue to identify examples of good practice in service delivery and then help support adoption and dissemination. They're also gathering information on the data being collected by rehabilitation services, and they will engage with the local education and training boards to discuss how they are planning to develop a workforce for the new models of service delivery that we know we'll need for a sustainable NHS. Following the initial report on adult services, we did make a commitment to review children and young people's rehabilitation services, and we are now embarking on this piece of work to establish if there is a case of need to improve these services also. Recommendations from this work will be taken forward in next year's work programme. Contact details for all the regional leads and our Children and Young People's Scoping Project lead will be available in the presentation published on the website, and I would encourage you to get in touch with us. In April this year, NHS England established the Rehabilitation Delivery Board to set the strategic vision for the programme and to develop a whole system approach to improving rehabilitation services. The board has made a commitment to work on 2 priorities this year, and these are return to work and meaningful occupation, and also long-term conditions. These reflect the priorities for the NHS as a whole, and were also reflected in the 5-year forward view that was published last month. This whole system approach is reflected in the diverse membership of the board, and we are working closely with colleagues from DWP to support the return to work element, and also with Public Health England to look at self-management and prevention in rehabilitation services. Because you're taking part in today's webinar, I know that you're already engaged with the work we're undertaking and are most probably a member of the community of practice. But we want to increase this engagement and hear from you, not only with examples of good practice, but for you to tell us what the barriers and enablers are to spreading that good practice and to take part in our debate and share your experiences. You can, of course, do this via the community of practice. Please post on the discussion forum, join in the conversation, and you can also now contribute to the soft intelligence gathering process by responding to the emails posted to you. These responses will help shape the future of the webinars that we're going to put on in coming months, but they will also contribute to the rehabilitation programme planning process. So please do engage with us and give us your opinions. You can also find most of our team on Twitter, so please tweet and join our conversations. We've got the rehabilitation hashtag that was on the first slide at the beginning of the presentation. And if you want to see the conversations we've been having up to now, you can use that hashtag, but you can also use the hashtag rehabilitation is everyone's business. Finally, we will be holding a second national conference in March this year. This will be themed around our priorities and showcasing further examples of good practice, and we'll have workshops designed to help you contribute. So Bruce Keogh is confirmed to attend the afternoon session and close the conference, and details on how to register will be available shortly. So finally, I'd like to just say a few words about how critical sharing experiences and sharing good practice is to improving outcomes for people. Sharing good practice contributes to the conversations locally, regionally, and nationally. You can offer solutions or support ideas for others, and what it does is it proves that change can be achieved. Some of the most vital information we need is what were the tools needed to achieve that change and how you did it. So please do continue to post on the forum and give us this information. As stated in the recently published 5-year forward view, there is no one-size-fits-all solution for transformational change, and we need to consider all the options for local solutions, but neither do we really need to let 1,000 flowers bloom, quoting the document, or continue to reinvent the wheel, because there will be a variety of examples available, and one of them will fit the local population need. We just need to know where to find them. We do consider sharing good practice so important that it is one of the major remits of our regional leads, and please do get in touch with them via email or via the community of practice. One of the other important things that we want you to give us information about is partnership and cross-boundary working, as John has demonstrated the importance of this and how it can really improve outcomes for people, making sure that we have a joined-up whole system approach. Thank you very much.
Thank you very much, all of you. That was very interesting and helpful from 3 very different perspectives. Just to say that our community has a website that you can go to post your comments and your ideas on, and there's a link here. It's very important that people keep this conversation going, that it's vibrant. It doesn't matter what your perspective is or where you're coming from. Exchanging thoughts, ideas will make it all the richer and all the more effective. So please, I would again endorse what Lindsey has just said. If you want to become a contact on that community of practice, there are 2 ways you can become a contact. Either as a named contact, and that's where we will share your email detail with NHS England and other related work streams, or you can become a general contact, and people who are general contacts, we don't share your contact details further, but you will get all the information information that we have as we get it as part of the email group. If you want to become a contact in any shape or form, please email Catherine at the email on that slide. She would love to hear from you, and we'd also love to hear from you, so do that. We have two different ways where we're specifically collecting information. One is around what you are doing. It doesn't matter what stage you're doing your piece of work. It could be in the planning stage. You could have completed and got wonderful results and great evidence. Whatever it is, there's a snapshot form available to you to complete. And I'd really endorse that, because it's been very helpful for us to share that with NHS England, for them to understand what's going on out there, and to share with the regional leads so they know about you and about your good practice. There's also soft intelligence. Now, it's that sort of stuff that you talk about with other people, that you talk about your own experience, and you don't perhaps think it's important. It's not hard evidence, as we were saying earlier in this presentation. It's all that kind of stuff that you talk about over coffee with your colleagues. It's very, very important, and we've got a series of questions that we've asked already on the website, and we'd like you to go to that website and have a look at those and see if you can respond and give us your views. We will keep on posting throughout the next few months, every couple of weeks, some more questions. Have a look. You've probably got some experience you can share with us, and please respond. If you feel you don't want to do it in person, you can do it as an anonymous posting, going via Catherine once again. So Catherine is the person to go to for anything like that. So there you go. That's a community of practice. Hopefully most of you are involved, and we would welcome anybody else who'd like to get involved. So now on to the interesting bit from my perspective, and this is about the questions that we've had in advance and some of the questions we've been receiving during the whole of this presentation, and they've been flowing through thick and fast, I can tell you. The first one that I would like to go to is, how will the community of neuro rehab services become more equitable and accessible in the future? It's just as important to have an upgraded capacity in the community as in the acute and post-acute rehab settings to allow whole networks to function. Lindsey, have you got any views on that?
Thank you, Jane. Looking at this question, I think my initial thoughts are really about providers and commissioners having conversations around a whole pathway approach to rehabilitation, obviously neuro-rehabilitation, but this could be extended to other conditions and other types of services. It's really important that there are integrated, coordinated pathways for the whole patient journey, and we've heard that from Penny and John, and I think that is where that conversation has to start to take place, to make sure that the whole patient journey and the outcomes that people want from that journey are addressed, and that does come between the commissioners and providers looking at the service delivery available and how they can improve that.
Has anybody else got any other comments they'd like to add to that? Penny?
I think almost we need to rehab the community to thinking differently in addition to rehabbing the clients, because it's a whole team effort.
Thank you, Penny. Anything from John?
We work with a service that's called communication support, and what happens is that speech and language therapists work with individuals, and of course they are a limited resource, so we're involved by having a communication support worker who coordinates around about between 15 and 30 trained facilitators of communication support services, and they work with the individuals and their family around the exercises and other activity that qualified speech and language therapists have laid out, and in that way you can bring in a lot of extra resource. And of course one of the big resources for people are their own families and their own friends, and too often maybe they are not seen as part of the solution that can help an individual to get the quality of life that they want, and they're rather kept out of some of the proceedings. So I think, yes, we do need to get people to think in a different way about things.
Thank you. So again, we're talking about a partnership across both the charitable sector, the families, the individuals to make this happen. We've had an interesting one that's come in while we've been talking. Do you see a time when we can look at savings across the system as a whole, rather than rehab savings in the NHS, as often the work we do impacts upon budgets outside of the NHS? Lindsey, do you want to take that one first?
Yes, thank you, Jane. This really sits in very well with the work that we're doing at NHS England at the moment. Whilst our priorities are on return to work and long-term conditions, we're also looking more widely at the general economic benefits of rehabilitation to the whole system. And that would include the Treasury around the Department for Work and Pensions, education services, also in the justice system. And I think there will be a time when we can actually look at the whole economic benefit of rehabilitation services, but we're only just starting that journey, and I don't believe it's going to be a quick fix. But I think the fact that that question has come in and people are starting to look at rehabilitation as being an absolutely vital part of the whole NHS health and care system, as well as society as a whole, then I think we will get there, but it will be a long journey, I believe.
Yeah, well, looking at my own case, I was told 20 years ago that I'd be the perpetual patient, that I would just go in and out of hospital, I'd have carers, and that's not the case. So all of that expense that was expected hasn't happened, and this just needs to become the norm.
Well said, Penny. I think that's absolutely right. John, was there anything from your perspective on that one?
Yeah, I think back to the National Audit Office report that looked into stroke services, which actually led to the national stroke strategies in all 4 countries being delivered. And basically, they said that without the acute services being put in and then being backed up by rehabilitation, the amount of money that the country was spending, around about 9 billion per year on stroke, would continue to rise. I think we've seen the first part of that activity occur, which is around acute services being improved. But we really do need to work towards a system where the cost and economic benefits that we know that come from effective rehabilitation, intervention, preventing secondary strokes, enabling people to avoid having expensive home care or going into residential care, unless we actually sort these things out and think of it in a whole system way, then we're not going to get the quality of life that we need for people. But also the draw on, you know, the economics is going to be far too great. So we have to continue to work to look at ways so that we can narrate the savings that come from one area of the system into other areas.
We've got another question here about the fact that, as we all know, there are different work streams that are happening within health and social care, and that sometimes, or very often shall we say, they don't work together. And how can we persuade, cajole, support, innovate to make them work collectively for the benefit of patients, regardless of their diagnostic group? Again, this is a big issue now for us because a lot of work is sitting in different repositories, in different streams. And again, I think we need to look at that.
I think from a patient's point of view, everybody, be it patient, professional, carer, needs to never shut up about it. The only way we're going to get this working quickly is just to keep talking about it, say, I know that you can integrate budgets, because people will do what's familiar and not what's new. I know there's a lot of pressure on people at work, and so it's much quicker to do what's familiar to you than to start something new. So I think we've just got to all bang on about it every opportunity we get.
Thanks, Penny. John, did you want to come in there?
Yeah, I think our experience has been that you need to introduce some disruptive influences into the system, and I mean that in a positive way, not in a negative way. I look at the way that the National Stroke Strategies evolved. That was because sitting around the table were all of the patient representative organisations, the charities, and stroke survivors and their families as well, which really helped to keep things being built around a patient-centric view, not just a partial view of one profession or another. And it's quite interesting because, no offence, but I look at the rehabilitation board or whatever, and I see maybe one service user and so on, but I don't see the voluntary sector around there. And yet I look at our organisation, we're dealing with 66,000 stroke survivors, and we form a huge component of what is actually being done along this patient journey. And the thing is that if you only see things in terms of medical interventions or care plans, things that are being done to a certain extent to people, I know it's more sophisticated than that, but that there is actually a need for the advocacy organisations who are saying, let's see if we can understand this from putting the patient right at the centre, and actually ask the question, would we really start from this place if we were really saying that this is about the patient and about the outcomes that they want? And, you know, in lots of situations, you would actually come to a view that you don't really want to start from where you are. You maybe need to look a little more radically. And, you know, whether the system will allow people to then take the radical decisions that need to flow from that, I don't know. But I do know that if you don't get the disruptive thinking in an early stage, then you're likely to get more of the same.
Would you like me to respond to that, Jane? Yeah, I'm in complete agreement, and I think there's a huge opportunity we're faced with, really looking at the sustainability of the NHS and how we have to look at systems and look at models to actually put the patient at the centre of their care, to treat patients and to give patients the care they need, where they need it, when they need it, and how they need it, and not be confined by the system as it's shaped at the moment. And I think we do really need to look at integration of all the possible providers and caregivers and contributors to make sure that we can actually make that difference to people's quality of life in that way. And I do think we are at a bit of a crossroads, and the opportunity is here for us, and we need to take it very promptly and move forward.
Thank you, Lindsey. Following on from John's comment, can I just ask, how can rehab services best build bridges with other groups, such as the voluntary sector, in order to access their input to the rehab journey? How can we get those bridges built, John?
Well, I think that we have a contradiction in a way, don't we? Because some of the things we're talking about here are actually going to need quite a lot of system change to be, you know, we talk about new models, and, you know, we want a lot of new models to come in. So that means that there needs to be some sort of central sorting of what models are appropriate and can be driven forward. And at the same time, what we've seen is a lot of devolution down to local decision making, and we're going to have health and well-being boards having more influence. But if we're going to try and work out what works, then we need to make sure that people who are working at a local level can access models that actually generally do work, so we're not engaged in constant innovation and reinventing the wheel everywhere. And that, to a certain extent, does mean that there needs to be some central suggestions about business models that work. But for those central suggestions to work, I would want to go on and say that other providers or approaches need to be engaged in the dialogue, and we need to get those potential disruptors. And I'm even at a local level, people can actually approach the charities or others who are delivering things at that level to actually say, do you have models that seem to work elsewhere? And I would like to see CCGs and health and wellbeing boards really working in harmony around these sorts of approaches, because there is huge expertise out there from frustrated survivors of various things and people who are living with long-term conditions. That needs to be brought into the mix along with their advocacy organisations, and there are solutions that can be found.
Thank you, John, for that. I think as a service provider, a lot of people out there are going to be keen to hear that and need to follow that up in order for us to change things out there. We need to be pushing this quite a lot more, I feel. This has been a really interesting debate, and it's great to hear that we're beginning to shift the focus much more towards the person who needs to have the support with their rehabilitation, not us doing rehabilitation to others in a way that we think is appropriate, but not to the individual who's receiving it. That's really key for all of us to keep in mind, whatever position we hold within the system. So I think that's great to hear. Penny's views is really helpful to hear that actually, in many ways, this has a better evidence, outcomes, and possibly costs. We don't know in terms of making sure we put the right inputs at the right time in the right place. John, your views around partnership working and making sure we focus on the things that matter for the people who have the issue to deal with, and being able to find ways of getting them to be the advocates and the people who are providing the support is again very, very key for us to take on board. And Lindsey, thank you for all your information about how NHS England is dealing with this and how it's really being recognised now that rehabilitation is a key point and very important to deal with the activities for people that they can get back to what they want to do, not what we think they want to do. So I'd just like to thank my speakers once again, Penny Robert, John Barrick and Lindsey Hughes. Many thanks, and thank you to everybody out there. Keep on posting on the community of practice, please.